Welcome everyone to the Shrier Family Topics in Rehab Sciences. It is my pleasure to introduce Dr. Nat Mayer. Dr. Mayer received his undergraduate degree from Columbia and his medical degree from the Albert Einstein College of Medicine. He's also a recipient of the Sheldon Beryl Clinical Service Award from the National Head Injury Foundation for his outstanding contributions to improving quality care, professional training, and education in the field of head injury rehabilitation. He's the director of the Motor Control Analysis Laboratory at Moss Rehab, with a special interest in utilizing dynamic electromyography, or EMG, as a part of movement analysis. The arrival of Dr. Dylan Edwards as the director of MRRI kindled in him an interest in combining transcranial magnetic stimulation with dynamic electromyography in study of patients with upper motor neuron syndrome. And that is what he's going to be talking to us today in his presentation titled Brain to Muscles, What's the Connection? Welcome, Dr. Mayer.
Thank you. So today's Shrier Family Topics in Rehab Science is supported by a generous gift from Nancy and Marc Shrier, and we're grateful for their support and belief in our mission. This is the disclosure announcement. I have no financial relationships to disclose. And brief objectives are to describe the characteristics of an MEP, description of MEP, absence, contraction plus hemiparetic patients, and to understand the concept behind the C7 nerve transfer in patients with hemiparesis. Now, what does the acronym MEP stand for? Is it Morse Rehab Exit Procedures? Is it Maxey's Elevated Play? Or is it Mayer's Exceptional Pierogies? No, it stands for a motor evoked potential. The MEP is a signal compounded from a series of descending corticospinal tract volleys with different generators. For magnetic stimulation, a brief high current pulse is produced by a figure-8 magnetic coil of wire. Here's what a figure-8 might look like. And this magnetic field is induced by the current passing through it, with lines of flux passing perpendicularly to the plane of the coil. So here's the coil, that would be the plane of the coil. And this is ordinarily placed tangential to the scalp. Magnetic fields can be up to 2 Tesla, which is not the automobile, but it's a intensity of magnetism, and it can last up to 100 microseconds. The magnetic field induces an electric field that excites nervous elements, leading to transmission of impulses down the corticospinal tract to the spinal cord, to peripheral nerves, to muscles that record the MEP, or the motor evoked potential. So here's where the stimulation would occur. Volleys are transmitted down the corticospinal tract. It decussates in the medullary pyramids, comes into the spinal cord, makes connection with peripheral nerves that go out to muscle, and then we have a surface recording of muscle action potentials. For TMS, or transcranial magnetic stimulation, there may be a less typical early D wave, the direct wave volley, which reflects activation of descending axons, but there is a series of later I waves, or indirect waves, that reflect synaptic activation of corticospinal tract neurons generated at different types of polysynaptic neuronal networks. What this means is that it's complicated as to what exactly is being stimulated. And we put in a little image of neuronavigation based on a person's MRI. And using neuronavigation, a person like Sapna, who knows how to operate a figure-8 coil, she can move in distinct and measurable locations in the brain, so that we know where the stimulus was applied. So here is a motor evoked potential. In this case, it has two phases. Sometimes it can have multiple phases. Here is the onset of the stimulation unit, the magnetic figure of 8 coil. This is the onset. And the onset of the MEP is over here at this onset, the takeoff. And so this period between stimulation and onset of the MEP is known as the latency. And the peak to peak is known as the amplitude. And then there is a silent period that is triggered after the MEP. And this silent period means that there is really no EMG until the EMG starts up again. So this has some variable duration as well. One measure of the TMS volley is the MEP amplitude, which depends on temporal dispersion and spinal mechanisms. When rotating the magnetic coil, the largest MEPs are produced when the current in the brain is directed in the posterior anterior direction and optimally at an angle perpendicular to the central sulcus. MEPs are also larger and earlier when the muscle is contracting as opposed to when it is at rest. 3 uses of MEPs in studies of behavior include understanding, execution, and performance of actions. It serves as a marker of physiologic change in the motor system. And there's a readout of upstream processes that influence the motor system. In reviewing relatively recent literature, I thought it would be worthwhile to talk a little bit about a paper by Shambra and her colleagues, because she described differential post-stroke motor recovery in an arm versus hand muscle in the absence of motor evoked potentials. So no sooner did I show you what a motor evoked potential was, but I'm now talking about the absence of an MEP. She indicates that recovery of movement in proximal and distal upper extremity muscles appears to follow different time courses, suggesting differences in their neural substrates. And this is commonly seen by clinicians, where a person has a good shoulder and elbow and has a terrible hand, or occasionally the hand is spared, but they have really severely affected proximal joint and muscular movements. The authors in this study sought to determine if the presence or absence of MEPs influenced the recovery of voluntary contraction and strength in the biceps, a proximal muscle, and the first dorsal interosseous, a more distal muscle. They tracked the relationship between corticospinal tract integrity using TMS-evoked MEPs and behavioral recovery using the Fugelmeyer scale in the biceps and first dorsal interosseous in 45 participants in the year after an ischemic stroke. They used EMG, dynamometry, and Fugelmeyer subscores to assess muscle-specific contraction, strength, and interjoint coordination. Participants were evaluated 5 times in the year following ischemic stroke using the 3 motor outcomes that were described. They used surface EMG electrodes taped in a belly tendon orientation over first dorsal and biceps. And they classified contraction presence or absence in 2 ways. Either the participants could produce some dynamometry, meaning they could get some tension development, or in most of the situations, volitional contraction was determined by the production of EMG activity that was greater than 50 microvolts during a contraction effort. TMS pulses were delivered with a 70 millimeter figure of 8 coil over the motor cortex M1, and they found separate cortical hotspots for first dorsal and biceps. Hotspot is where you get the best response for an MEP in the rest circumstance. They studied rest. So they studied muscles at rest, and the presence of an MEP or the absence of an MEP, MEP minus of a resting MEP was delineated by a peak-to-peak amplitude greater than 50 microvolts and a latency within 40 milliseconds. Volitional muscle contraction using EMG, strength using a dynamometer, and Fuglemeyer was the behavioral assessment, were done after they did their TMS testing. And here's what they found, that there were patients who were MEP minus, but contraction plus. That is, they could produce EMG of either the biceps or the first dorsal interosseous, but they still weren't unable to generate an MEP. So this is the percentage of each group, and you see that a small percent of these patients were MEP minus, but contraction plus. Biceps were more people early on who were MEP minus, but they were contraction plus. They could produce EMG volitionally. But even at 52 weeks, there still was a group of subgroup of patients who were MEP minus, but contraction plus. What this means to me is that the volitional effort didn't come through M1, through the corticospinal tract pathway. Interestingly enough, there are some patients who are MEP minus and contraction minus, and that goes down to basically zero by 52 weeks. Now, when they looked at strength, the absolute strength, both the paretic hand and the arm were weak following stroke, but having an MEP was associated with significantly greater strength than having no MEP at all. And that was true for both the paretic first dorsal and for the biceps. And when you looked at Fuglemeyer scores, they looked at a subscore, which was really section A of the Fuglemeyer. And that has a maximum of 36 points on it. Not the usual 66 that many of us are familiar with when we read these papers, but they used the subscore for section A. Maximum score was 36. That's why you see 35 on the y-axis. So the Fuglemeyer score reflects abnormal movement in the shoulder, arm, and forearm and excludes the wrist. That's why you lose some points there. Both the paretic hand and arm had reduced Fuglemeyer scores following stroke, but having an MEP was associated with significantly higher Fuglemeyer subscores than having no MEP at all for both the hand and the arm. And hand and arm recovery curves behave largely similar in the absence of MEPs, arriving at a recovery plateau at about 12 weeks. There's the plateau at about 12 weeks for the arm and for the hand, and not converging on their counterparts with MEPs. So the green represents MEP plus, and the red or the hot pink is MEP minus. When an MEP in the FDI or biceps was present, participants could almost always volitionally contract the muscle. When an MEP in the FDI or biceps was absent, a modest proportion of subjects could still volitionally contract the muscle. The odds of this MEP minus contraction plus condition were over 4 times higher in the paretic biceps than the FDI. In their supplement, they pointed out another interesting phenomenon, and that is that some patients who were MEP minus and contraction plus converted to MEP plus contraction plus during the course of recovery. And that's this blue graph over here. These are converters during the course of recovery from the first month, from the first week post-stroke through 52 weeks. And you see that even at 12 weeks, there was a fair amount of conversion, and there still was even more conversion at the 52-week marker. And that was true for strength, and is also true for the Fugl-Meyer behavioral score, that there were converters who then improved their Fugl-Meyer score. So in summary, findings of MEPs resulted in a higher likelihood of EMG muscle contraction, greater dynamometry strength, and higher Fugl-Meyer scores. But there were cases of MEP minus contraction plus, and in cases with absent MEPs, the biceps could more often volitionally contract, was less weak, and had steeper strength recovery curves than the first dorsal interosseous. In contrast, Fugl-Meyer recovery curves plateaued below normal levels for both the arm and the hand. And the authors therefore concluded that there are shared and separate substrates for paretic upper limb recovery, and corticospinal tract integrity was necessary for interjoint coordination, which is another phrase that she uses for Fugl-Meyer tasks, in proximal and distal segments, and for overall recovery. In MEP minus contraction plus cases, alternative pathways, and she speculated that maybe it was the reticulospinal tract pathway, these alternative pathways may assist recovery of volitional contraction and strength, particularly for the biceps. But we don't really know where the source of electromyographic activity is for muscles that were MEP minus. So reticulospinal tract was a speculation, but it could be something else.
Can we
Now,
can I ask a question?
Yeah.
So if you go back 2 slides to the the converters, those are kind of interesting.
Yes.
So 2 questions. One is, did they talk about what proportion of their sample was these converters? Were these really outliers, or they represented a significant proportion of their sample? Because there is a lot of work coming from the predictive models where people are trying to use MEP very early on as a biomarker for upper extremity recovery, and people have used that. Like, for example, Kathy Steinier's work, she uses MEP amplitude as one of the biomarkers for upper extremity recovery. So in that case, if these converters are a significant contribute or a significant proportion of the sample, then that might in some ways help explain the variance why MEP early on may not be a great measure. And then what is different about these people?
Well, that brings up an excellent discussion. First of all, there were just 45 patients in this sample that she used. That's not a lot of patients. I don't recall the actual number of participants that had this conversion, so I can't help you there. But what she's doing is saying that when you follow a group of patients with a trajectory, there are at least some, there's certainly more than 3, there are at least some who show this conversion phenomenon. And so Steinier's model is a little bit, not suspect, but you remember that she only covered 75% of the variance. So 25% of the variance wasn't covered, and maybe there were some of these converters. The other thing is this, and I don't quite understand it. How can you make a generalization about corticospinal tract integrity when you are not tracking all of the connections of the corticospinal tract? Shrier used one or two muscles, was FDI and first dorsal, and I think extensor carpi radialis. In this study, we have the biceps and first dorsal interosseous. And I don't think I'm going to buy the idea that we cover all the proximal muscles with biceps and we cover all the distal muscles with first dorsal interosseous. So I don't understand how we can use the language of corticospinal tract integrity when we're only having a sampling. So that's what I could add to what you were saying. But it's clear that the Shrier model is going to have to be modified from this, because other people have also found MEP minus contraction plus patients. Well, let me
Another quick question. I'm
Yeah.
sorry, Nat. Hi.
Go ahead.
Hi. What's the reliability of MEP evocation within a single subject, within a single, like day 1 and day 2? Is it a consistent and reliable enough signal that the absence of an MEP on a given day can be very highly counted on to be really a true measure of excitability? Is it possible that there are, there's vagaries in exactly how the coil is held that day, or something that might explain also? Is there noise at all, or is it a crystal clear indicator?
She could probably answer that better than I could, but I'm going back to her technique at the hot spot. 10 stimuli at 100% maximum stimulator output were delivered with the muscle at rest with an interstimulus interval of 5 to 7 seconds. So she's trying to use multiple stimuli, and they're moving the coil all around, and they're pretty good with their technique. And of course, the absence of something isn't always evidence of absence.
Right, that's my point.
Right, and of course, technique is very important. But other people have reported this, and in fact, she picked up a study from the 1990s where they also made this comment from their findings, but she said that their stimulation intensity was suboptimal. And so she was questioning the technique. So here she went to 100% of the stimulator output. And of course, they looked at the non-paretic side as well, and they got, good results. And you sort of, go to the affected side and use the same technique, and you hunt around. So I would think that technique is not going to be the answer to why she didn't find MEP.
Or why she got conversion, yeah.
Well, the conversion, she used the same, but with the conversion, she used the same technique for all of them. That's the claim. Well, we've all done research, and Monday is not always the same as Tuesday. Look at the Phillies.
I think we are looking at presence or absence of MEPs. We are really not looking at MEP amplitude, which is highly unreliable. We don't know how how this absence of or presence of MEPs changes over the course of recovery. But if we take chronic patients, one can be quite certain about the reliability of presence or absence of MEPs in chronic people across days. We will not be, the reliability of the MEP amplitude will be, is quite,
yeah, that's different. Yeah,
that's different. But yeah, presence or absence would really rely on the integrity or the amount of corticospinal tract that is available, I would think.
Well, others are going to have to repeat this study in some way to verify it. But she's not alone in picking up the MEP minus contraction plus finding. Now I'm going to switch a little bit to get background to what I was going to present today as information from what we're doing. And this is from the Journal of Physiology. It's by Marc Shrier. And he points out that in the Penfield model, you have these discrete separate zones of hand, wrist, elbow, and shoulder. And all of us are familiar with that, but this is the first half of the 20th century, more or less. And he asked the question, do 21st century data of electrical stimulation of the motor cortex demonstrate a sequence of discrete separate zones representing the shoulder, then elbow, then wrist, then hand, a la Penfield's homunculus? And he says, no, they do not. Instead, the data show what has been termed relative somatotopy, namely a gradual progression in which shoulder movements are represented medially and hand movements laterally along the central sulcus, each overlapping considerably with elbow and wrist movement representations in between. In other words, each part of the upper limb is widely distributed within the overall representation. And so this is the central sulcus, and this is neurosurgical work by neurosurgeons who used more recent technology and stimulation. And the green represents finger movements that were obtained with stimulation, and the arm are these plus minus markings. And you see that there's an overlap over here. There's a big overlap. So that's going to come into play in a moment. This is a case we had. A middle-aged woman sustained a deep right basal ganglia hemorrhage with increased brain swelling, requiring a right hemicraniectomy in the late spring of 2021. She underwent cranioplasty 3 months later with titanium plates. And you can do transcranial magnetic stimulation with titanium plates. And she had a severe left hemiparesis residual with a Fugler-Meyer of 4 out of 66, with some spasticity when she was seen about 6 months after stroke. On this date, initial testing of TMS applied during flexor and extensor synergy efforts did not reveal MEPs on the affected side. But because EMG voltage was low, she was asked to return for right and left upper limb isometric testing with TMS. Now, here I'm showing isometric abduction of the shoulder on her unaffected side. And we have muscles, 16 muscles with recording. Why is this here? Okay. Did I lose it? I want to go backwards. What happened? What happened here? Okay. So we have muscles proximally from the upper trapezius, the anterior deltoid, middle deltoid, biceps, FCR, first dorsal interosseous. So we're up and down the arm, 16 muscles. And here's Mary Ferraro, who is applying a restraint to abduction on the unaffected side. And here you see for abduction activity in upper trapezius, anterior, middle, and posterior deltoid, and even a little bit in infraspinatus. And over here, at this point, there was TMS applied, and we have TMS onset over here. And you see here's a silent period. This was saturated MEP. Here's an MEP in the anterior deltoid, middle deltoid, serratus anterior. And we see that even in FDI, distally and EDC and FCR, there are lots of MEPs going on over here in one stimulation site. And that's why I showed that map from Shrier to show you that a lot of cells related to different muscles of the arm are close to each other. It's almost like if you built a house and you had the bedrooms on the 3rd floor, Would you put the bathrooms in the basement? No, you'd put them right next to right next to your bedroom. And so it seems to me that the cells that relate to all the different muscles of the arm are going to be near each other, which is not exactly what Penfield was signaling at his time. And here is isometric, unaffected isometric flexion on the unaffected side. And you see activity, especially in the biceps and brachioradialis, and a little bit in upper trapezius. And here we see an MEP in the biceps and especially in the brachioradialis, but there are also some distal MEPs, and it looks like there may have been an MEP in the right upper trapezius. And this is how Mary tested the patient. So that's the unaffected side. This is the affected side. And here's Mary testing her isometric flexion. And you see that she does activate biceps and brachioradialis. So this is contraction plus. But when you go over to look at whether an MEP was generated, all you see is EMG activity. So this is a case of MEP plus contraction, contraction plus MEP minus, contraction plus MEP minus. In the Chambers study, she speculated that it was the reticulospinal tract might be involved. And that was in 2019. In 2021, another paper by Hammerbeck and his crew stated that the strength of the corticospinal tract and not the reticulospinal tract determines upper limb impairment. So these are going to be continuing battles until more studies come out to figure out what is the source of contraction of a muscle in the absence of presumably corticospinal tract innervation. Now I'm going to give a little background to the next case. And with the next case is a transfer from the unaffected C7 nerve to the affected C7 nerve. So here's a lesion in the right brain, and the right brain, goes to the left arm. So that's the orange and orange. The right brain controls the left arm, and this blue is cervical spinal nerves coming out, especially the C7 root, and it's going to be transferred over to the root on the paralyzed side. And here's another look at that. We're going C7 transfer over to the affected right side. And how do they do it? It's not done with mirrors. It's really pretty amazing to me. But they take that cut non-paralyzed root and they slip it behind the esophagus and in front of the vertebral column. And so they go through this route over here, then they suture it together, they anastomose it, and now you have the unaffected C7 root transferred into the affected side. Who did this? This was done by a bunch of guys in China who originally were doing transfers for brachial plexopathies. And then one of them got the bright idea, or maybe a bunch of them got the bright idea to try it in patients with stroke. There were 36 patients, unilateral arm paralysis for more than 5 years. So they're well into the chronic stage. 18 underwent C7 nerve transfer plus rehab. 18 patients underwent rehab alone. What was the primary outcome? It was a change from baseline to month 12 in the upper extremity Fugl-Meyer score. And what was their result? In the patients who had the transfer, there was an increase of 17.7 units. That's very significant clinically. In the control group, it was 2.6. It was basically no real change at all. Spasticity was also less in the C7 transfer group. And TMS and functional imaging showed connectivity between the contralesional hemisphere and the paralyzed arm. There's some very nice images that you could see in the paper. I didn't put them in, but it was accepted by the New England Journal of Medicine. So it has a good pedigree. And what about the arm that they took the unaffected C7 nerve? Did that get weaker? Initially it did, but by 12 months, the power, the tactile threshold, 2-point discrimination of the donor graft or the unaffected limb was, there was no difference from baseline. So they concluded that in this single center trial of patients with unilateral arm paralysis due to chronic cerebral injury for more than 5 years, transfer of the C7 nerve from the non-paralyzed side to the side of the arm that was paralyzed was associated with a greater improvement in function and reduction of spasticity than rehabilitation alone over the period of 12 months. And the main thing was that physiologic connectivity developed between the contralesional, that is the unaffected cerebral hemisphere, and the paralyzed hand. So a connection was made. In case 2, we have a middle-aged woman developed a right hemiparesis due to a left brain stroke in April of 2020. About 6 months after stroke, she underwent contralateral nerve transfers from the unaffected left side to the affected right side. So this is the first case in Philadelphia, and she was then referred to Dr. Chow for rehabilitation, and that's how we got to know this lady. But this is the first case in Philadelphia, and I think the first American case overall. In this situation, the surgeons did a total of 4 nerve transfers, including anterior and posterior brachial plexus divisions of C7, and the C7 contribution to the lateral pectoral nerve, and the C7 contribution to the long thoracic nerve. So here are the anterior and posterior divisions, and they eventually feed into the posterior cord, and the posterior cord goes downstream, becomes the radial nerve, and that innervates the triceps, the wrist extensors, and the finger extensors, and also some finger flexors as well. And then they also did a transfer for the lateral pectoral nerve out here, and also for the long thoracic nerve. Now, what does the lateral pectoral nerve do? It innervates the clavicular head of the pectoralis major, the clavicular head, and also sometimes sends some branches to the sternal head. But this is the clavicular head because it comes off of the clavicle. And the long thoracic nerve in green here, that comes down to our friend serratus anterior. And it's called serratus anterior because you can think of your serrated knives and you can see the serrations that are involved. This is a very important muscle because it inserts on the underside of the medial border of the scapula and allows the scapula to protract forward. And I first met up with this when a brilliant surgeon at Temple Hospital had a patient who had winging of the scapula. And he said, in order to stop the winging, he was going to suture the scapula to the thorax. And I think he did. And then the patient couldn't reach forward because the scapula couldn't protract. So that's a very important muscle, and it's a scapular muscle, and therefore really should be studied in all of these patients, not just looking at deltoids and biceps and triceps, but scapular muscle are really important as well. And in this patient, we had her move a box with a weight on it, and she was attached bilaterally. Her right hand has some Coban on it so that the hand doesn't slip off because this is her paretic side. And here she's moved the box forward. So you can see starting here, moving there. There is a magnetic switch here. That magnetic switch is going to trigger the TMS that Sapna is holding over here, the wand. And let's see what that looks like.
Ready. Sapna ready. Start.
That little click is what you heard was the TMS, but it was triggered by the patient so that we could trigger it at the same time each time, same place each time. So this is bilateral forward push of a box in a track. And TMS is applied to the right contralesional or the unaffected brain. So it's applied to the right brain. And so we have here a nice MEP in the anterior deltoid on the left. And we have a nice MEP in the posterior deltoid on the left. And we have a nice MEP in the unaffected left pectoralis major. But look at this. This is the right side pectoralis major, and here's a little MEP. It's 142 microvolts compared to 1258 microvolts on the left, but it is an MEP. Latency, not too bad, 22.6 milliseconds. But this is stimulating the unaffected brain. Now, how can you stimulate the unaffected brain on the right and get a right-sided MEP? That's because of the transfer. The nerve was transferred to the lateral pectoral nerve. And so we have some evidence here that the transfer is beginning to work. We did not get anything in the serratus anterior on the right. So it doesn't look like it's caught up. And also notice that we've gotten some nice MEPs on other left-sided muscles, lateral triceps, ECRB, FDS, and even the medial triceps. And this is just from one stimulation site. Come on, guys. How does this go? Oh, there we go. Okay. This was another push with that box. And here you see that there is activity in the left anterior deltoid. That was the unaffected side. But interestingly, there is some activity in the right anterior deltoid. So there is some connectivity from somewhere to the right anterior deltoid. So that would be at least contraction plus. But we're not on the correct side to see if there is an MEP from the affected brain. But here is another example of the MEP in the pectoralis major on the right, which we think originates from the transfer. And in this figure, we did 5 different tasks, 2 isometric tasks, 3 different push tasks, and all of these produced amplitudes greater than 100 microvolts for the MEP in the right pectoralis major, and a reasonable number of latencies as well. So our impression was that there were MEPs in the right pectoralis major with right brain stimulation, reveals evidence of regeneration of the C7 contribution to the right lateral pectoral nerve transfer, which innervates now the right pectoralis major 5 months after the transfer. But we didn't have evidence of regeneration to serratus anterior or to the medial lateral triceps. But we're still waiting, and we will test her again in several months and follow this out for a year, because it's a long way to go for the nerve to sort of regrow from where they made the transfers all the way down to extensor digitorum communis. The last thing I wanted to present was a patient who is flexing the elbow, extending the elbow, flexing the elbow, extending the elbow, basically doing alternating flexion, extension, flexion, extension, flexion, extension. And here's the brachialis. The brachialis is an elbow flexor. The EMG is activated during flexion phase of the movement. It's off during extension phase, on during flexion phase, off during extension phase. So the brachialis is on, off, following the alternating movement. And in this muscle here, this muscle is active during extension phase. Extension phase, the purple is active during extension phase, extension phase. Which muscle is this? Turns out it's the biceps. Now, wait a minute. The biceps is an elbow flexor like the brachialis. So why is the biceps out of phase? Why is it active during extension rather than flexion? How does that work? Well, this is a record from a person with C5 quadriplegia. And there was a biceps to triceps transfer, so that the biceps was taken away on the flexor side and then attached onto the distal end of the triceps, which goes into the olecranon. And now the biceps mechanically is in position to extend the elbow. And this doesn't happen immediately after surgery. A period of training in occupational therapy is necessary, but the brain learns to use the biceps as a functional elbow extensor. So our last slide, brain to muscle, what's the connection? We see that in some situations, you can have a corticospinal tract connection. And here are the MEPs going through M1 for a variety of muscles. This was isometric abduction. And we have MEPs in upper trap, anterior deltoid, middle deltoid, posterior deltoid. But in some situations, there is a different type of motor tract connection where you have contraction plus on the EMG side, but MEP minus on the MEP side. So this doesn't seem to be coming through M1 in the usual way. And here is an MEP where there was a contralateral nerve transfer. So it's a different kind of connection with evidence that the unaffected brain is now controlling the transfer muscles, not from this image, but from the study that Schengen et al. Did. And finally, peripheral muscle transfers can occur where the brain relearns to operate a muscle as a particular mechanical way. In this case, a biceps as an elbow extensor. And here's a patient who had a biceps to triceps transfer on his right side, and he can extend his elbow against gravity while lying on his back in bed, but he can't extend the left because they didn't do the transfer yet. So as John Donne said, no man is an island, and these are all of the people involved in these studies, and I'm most grateful to all of them, to Dylan, our mentor, Josh, who's from Drexel, Sapna, who is par excellence, a great stimulator and very knowledgeable in the literature, and a great artist as well. We have to mention that. Cheryl, our coordinator, Ning Chow, Dr. Ning Chow, the director of the stroke service, who has a great interest in all of this and keeps me up on my toes. Mary Ferraro, who is just a tremendous asset for all that we do, and Lynn from the OT Hand Clinic, who is just great as helping us out with all of our splinting needs. So with this, I'll end my talk and entertain any other questions about what we've shown.
Thanks, Dr. Mayer. Oh, shall I?
No, I was just going to say thank you for the presentation.
I was wondering, can I ask a quick question if I'll lead off, shall I?
Yes, yes, please.
So super intrigued about the C7 nerve transfer and exciting that it could be one of the, if not the first case in the US. And I'm not bothered that there's not a connection. It's only been 5 months. So I believe the literature suggests it can take up to a year before you'll get active reconnection, especially for more distal muscles, say the wrist extensor. I was just wondering, so the pec major MEP is exciting from stimulating the same side, going down as if it's going to the left side, but then crossing over and innovating the right pec major. I was wondering a couple of things, maybe to get some more MEPs. So I know the neurosurgeons, the evidence of just one MEP is enough for them to avoid chopping in a particular area with the brain surgery, but perhaps a string of MEPs would be more convincing and they could be overlaid. And the other thing I was thinking is to do, what did Dr. Shrier show with his peripheral nerve stimulation? Because if you stimulate in the, I'm wondering if you stimulated Erb's point, I think it is, whether you can prove that there's peripheral connection that would corroborate with the TMS stimulation as well. So it'd be nice to show that in parallel, that there's, it's not just an MEP, but it's also showing the peripheral connection, if that's even possible with the nerve transfer.
No, it absolutely is possible. And the MEP that we showed, there actually were 5 MEPs. There were 2 isometrics that were separate.
Ah, perfect. Okay, so,
and then there were 3 push tasks. So we had 5. We had. Let me see if I can get that slide.
No, I believe it. That's terrific. Yeah, always more than one is
Right,
more convincing.
There were 5. There were 5 different ones. 3 push and 2 isometric. That's the shortest distance that it has to traverse. Let's say an inch a month. So if you want to get down to extensive digitorum communis, if your sleeve length is about 32 inches, maybe the distance that has to be traversed is about 24 inches, or so it could be a long time. They got a lot of recovery in the other place about at 12 months. That's when they saw that in China, where they saw the EDC and the wrist extensor. So it does take time. What's hazardous is whether fibrosis blocks the regrowth of the nerve. I mean, that can happen. So they have to be able to do it in a way in which you don't get fibrosis. So in any one situation, one doesn't know whether one will get it or not for technical reasons.
So
No, go
ahead, Dylan.
Well, just quickly, I was thinking, just thinking about the merit of this particular approach. I know that they lose a little bit of function in the nerve that's harvested going out to the healthy muscles, but that recovers, so that's fine.
Right.
Do you expect, because that's the beautiful thing about the brachial plexus, it kind of divides and has lots of pathways down to innovation, but do you expect that if you stimulate the affected hemisphere that you could still get a MEP in those muscles? I didn't think about that before. So the usual pathway to the hemiparetic arm where you don't really get a response or you have a weak response, as you've shown, is it still possible that there's enough left potentially to have a normal functioning, a normal functioning corticospinal, not normal, but to allow recovery of the conventional pathway from ipsilesional to the hemiparetic side? Right. I suspect yes. I suspect there would be. So then you would have both hemispheres driving that same muscle.
Yeah. Now in the China study, they established a baseline that there was not an MEP. on
Yeah,
the
but as you
active
showed
part.
in the earlier slides, you might recover some, it's plausible they could recover function of MEPs.
No, no, in the Chinese study, that was done in people who were 5 years post.
I see.
So they were already in an outcome category.
Yeah.
And then they were selected in part because they didn't have an MEP.
Got it.
And their objective was so, but the patient in Philadelphia, I do not believe had any neurophysiologic studies before they actually did things. So it's possible that she could have had an MEP to the pectoralis major, but we wouldn't have known that. We only got her after the transfer. On the other hand, we did stimulate the affected hemisphere, and we didn't get MEPs in those muscles, even though we did see contraction. As I showed you, we had contraction in the anterior anterior deltoid during the push test.
And
So,
so,
yeah, so she was MEP negative, but contraction positive.
so she was MEP negative in the deltoid, right?
Yeah, in the deltoid, yeah. That's what I remember now. She probably was in other muscles too, but right now I only remember from my slide that I showed you that there was activity in the anterior deltoid.
Okay, that answers my question, because I was wondering if there could be some ipsilateral pathways that could contribute to that MEP, and if we are not seeing them in deltoid, but we are seeing them in pectoralis major that has received the innervation through that transfer, then that answers my question that it is through that transfer and not through ipsilateral pathways.
Well, maybe Sapna can comment about the ipsilateral pathway. That's one of her favorite pathways.
Sure, Dr. Mayer. Thanks for the great presentation. I also wanted to add another comment about Sailesh's question earlier on the converters, the MEP converters. So that's a great point, Sailesh, and that's one of my interests as well, in terms of how it relates to the missing piece in Stinier's work. And I think the ipsilateral pathway might be one of the missing pieces as well. But what we have seen in some of the other patients, it is with chronic patients, at least more than 6 months post-stroke is what we define as chronic. The ipsilateral pathway, other than the CFC, if at all, shows up as MEPs. It's mostly delayed, and we are able to obtain it in a different stimulation location site than M1. It's mostly premotor areas that we are able to get what we think might be RST-like pathways. But with this patient, we tested only the motor cortex, and we did test with the same set of muscles by stimulating the ipsilational as well as contralational site. And like Dr. Mayer said, we obtained no MEPs in the ipsilational conventional pathways, and there was only the PEC major activity in the nerve transfer pathway.
I see. Cool.
See, that raises a whole other spectrum of questions, and that is that M1 is has a very specific set of muscles for the actuators that are going to be involved. But if you go into the premotor cortex, maybe the SMA or other parts of the premotor cortex, there is evidence from the work of Liu that the representations are more abstract. And because they're more abstract, that's what Liu thinks enables us to write our name on sand on the beach when we've spent our whole life just writing with our right hand, or writing with our left hand when we spent our whole life writing with our right hand. And the question is, how does the execution with a different limb, where does that get its information when it's very specific to use your right hand and right muscles? And his idea is that there's a more abstract representation of the actions that are involved, but it doesn't select for the specific actuators. And what does he base this on? He bases this on a number of patients who were born with dysplasia, where they had no hand and no wrist. And they were able to activate those same premotor areas that the hand would, a person with a hand would activate, but they activated it with the leg, because these are all people who use their legs for grasping and for writing. And so there are several different layers of activity. And it raises the specter of, can you use the more abstract representation of action to find a set of actuators that are available after a stroke, as long as the stroke hasn't involved, the more abstract representation of action. So that may be another way in which recovery might take place. But these are all things for the future.
I think there is a more simpler explanation in terms of activation of the premotor cortex, because premotor cortex does contribute to almost 30% of the corticospinal tract. And I don't know, I mean, maybe other people who work at a more higher level might be able to help here, is I don't know if there is a particular representation in the premotor cortex that allows for an abstract. I mean, I don't know how, if it's just within the premotor cortex, or would it involve a network? But again, as you said, questions for the future.
Yep.
All right, I think we are well beyond 1 p.m. So thank you so much for your attention, and thank you so much, Dr. Mayer, for the presentation.
Okay, thanks a lot.
Thank you
guys.
very much.